well, a topic that is close to my heart, clearly not as close to many of your hearts, but still, I will interweave some different topics. I want to talk about the window of vulnerability. Now, the window of vulnerability is that period between recovering from your C. diff event to the next time it appears, and that period. That period is called the window of vulnerability. For those of you who know me, tend to know I have a British sense of humour, so that will come through in a few moments. I'll speak briefly about diagnostics and how they can be important in recognising events during your window of vulnerability. And then I think what's very important is to make sure that those of you who do have C. diff can make moves to actually avoid these future recurrent events. Dr. Feuerstadt showed you very many implications and problems associated with recurrent disease. I'm hoping that by the time I finish my presentation, you'll have some ideas of how to potentially avoid those or reduce the chances of them happening. So, window of vulnerability, diagnostics, and the transition. So, as I say, British sense of humour. You go from, you've had your C. diff, you go back into the community, and the sharks are circling. You can all hear the noise from Jaws. You know what it's like. I'm not meaning to belittle the condition, but hopefully this will stick with you. That C. diff is a dreadful condition. You know that far better than me. So my buddy made I believe it's called an avatar. So there you go. What is the window of vulnerability? How long is the window of vulnerability? I'll tell you in a moment or two. How durable are different therapies, such as fecal microbiota transplantation that was presented just now? What are the factors that can drive this phenomenon? What can we do to reduce this phenomenon? And that, I think, is where I try to pull everything together to avoid or minimize the chances of the disease. So, clinical trial there was actually, I was actually involved in probably about 12, 13 years ago. I experienced fidaxomicin, and we looked at when recurrences occurred. Now, we were looking for a sustained clinical response. How long did the antibiotic take to clear your symptoms, and how long were you clear before the darn thing recurred? And we called it early recurrence, which tended to be the first 14 days, and you can see here most of the recurrences that did happen occurred in that period. And you'll see that vancomycin was responsible for more of those than fidaxo. But still, look at the tail that goes out to almost 40 days. And that is the period that people sort of, I won't say forget about, but are really not aware that that's likely a recurrence of your condition. So, window of vulnerability is that period beyond 14 and 15 days when you really, you're not sure what your diarrhea is. So, some recent data for you. So how durable is the therapy that you've just been given? So let's talk about fecal microbiota transplantation. And a study that was published by Jessica Allegretti from up in Boston. They studied 400 patients, and they had a mean follow-up for 18 months. And over 90% had a durable response. But antibiotic use was associated with recurrent disease. But there was no difference between those patients who received an anti-C. diff antibiotic prophylaxis and those who didn't. So, is prophylaxis of benefit? Probably not. But probiotic prophylaxis was actually associated with a greater risk of recurrent disease, which I think is sort of counterintuitive to some extent. Then there was a study from Saha et al., and they looked, again, at the durability from FMT, and they looked at additional risk factor exposure, and they again studied over 400 patients, and 375 of them had more than one risk factor: age, gender, liver disease, and so forth. So you can see there the list of risk factors. And it's not just one risk factor. It can be, an accumulative number. And they followed patients for a year. And they showed that over 78% of patients actually were clear of recurrent C. diff. And that was from the FMT that was provided. And you've heard good data from Dr. Hirsch about that. And then a therapy that is often used, vancomycin taper or vancomycin pulse. And that means you get your vancomycin every other day or every third day. It's fairly complex, but nevertheless, it has been shown to be, pretty effective. And really, that was introduced before FMTs were around or more readily available. And 100 patients, and this was from Siabu's work, published about 5 years ago, they looked at 100 patients and they were followed for 90 days. And again, 70-something% had a good response through to 90 days. And if you actually thought about the pulsing, 81% had durable response. Now, what's not on here is recent data that was provided on patients who were followed for 2 years. And again, they've got really good responses, greater than 80%. You see here 70% is the norm. So we're looking at patients who were followed for longer. And again, it was actually live biotherapeutic that was used in that case. Most studies tend not to go that far. So the durability is an example of how the window of vulnerability can be managed. What can increase the risk of recurrent CDI after you've finished your vancomycin or fidaxomicin? Well, as was stated previously, antibiotics are the bad actors here. They clearly do play a role for the reasons described before about inducing a syndrome of dysbiosis. Basically, antibiotics can go in there and be like napalm. They can wipe out all the good bugs. The other medication that is associated with recurrent C. diff are PPIs, or acid reduction agents. Now, there have been various meta-analyses that have shown that PPIs are implicated with recurrent disease, less so than antibiotics, but still, they do have an impact. And you can see here a meta-analysis of 16 studies where they looked at age and other potential co-founders. There was an increased risk of CDI when you use a gastric acid suppressor. And you can see there that the OR is 1.38, so that's a significant influence on getting a risk of recurrent CDI. Hospitalized patients, PPI use was associated with an 84% risk of getting CDI versus not receiving gastric suppressants. Ironically, there was a study which was in mice, so I don't know whether that really equates to us, but they actually showed there was no impact of omeprazole on C. diff. But I think the human work is probably more related. And the other set of medications that have been shown to have an impact are immunosuppressants. And again, significant result, 0.04 in probability of immunosuppressants driving recurrent disease. Work from, 10 years ago now, Drajonka et al. Looked at the implications of antibiotics. No antibiotics, antibiotics during therapy, and antibiotics in the 3 months following your therapy. And you can see that almost half of the patients who received an antibiotic post their C. diff therapy had a recurrent disease. So antibiotics are bad news. I tried to, as is normal with me and sort of spectrum of situations, I've got traffic lights here. We've got red, yellowish, and greenish. High risk. What are the high risk antibiotics? I think Dr. Hirsch mentioned a patient who was on ciprofloxacin and developed C. diff. I must confess, I always take a breath when that sort of case is mentioned, because I actually was one of the developers of ciprofloxacin a long time ago, so it makes you kind of step back a little bit. Anyway, fluoroquinolones generally, second, third generation cephalosporins, and for those of you who are young enough to remember, this condition was originally called antibiotics-associated diarrhea, and the villain of the piece at the time was clindamycin. And clindamycin was used, it was almost in the water supply. It was so popular. And clindamycin is the bad boy. However, I should imagine a number of patients that go to the dentist and have some form of procedure, they usually get clindamycin to prevent an infection. So dentists need to take heed. Moderate risk macrolides, azithromycin, clarithromycin. I was surprised to see trimethoprim sulfur in there, and some of the sulfonamides as well. Low risk, aminoglycosides. Don't worry about bacitracin. That's a strange antibiotic that goes back a long time. But you've got metronidazole, vancomycin, chloramphenicol, and so forth. So it really does relate to the spectrum of activity. How many bugs do those antibiotics kill? And the high-risk ones, as I say, they're like napalm. They take a lot of organisms out of your bowel, the protective ones that you heard about previously. So just to prove that clindamycin's the bad boy in here, data from Dale Girding's group 30 years ago, they looked at intra-abdominal infections. Now these patients receive an antibiotic to prevent or further prevent serious infections in intra-abdominal case. So they looked at randomized study, intra-abdominal infections. They looked at patients that received amikacin, which is an aminoglycoside, metronidazole, placebo, amikacin, clindamycin, placebo, or amikacin, clindamycin, and ampicillin. Basically, if you look at the data there, let's go to the bottom. Group 1, which is the amikacin, metronidazole, placebo, none out of 13 had C. diff. Those groups that had clindamycin, you can see there was approximately 1/3 of patients who developed recurrent C. diff. I think that just goes to show that antibiotic-associated diarrhea was a real thing even 30 years ago. So what are the things that can positively impact your window of vulnerability? Probiotics, sort of ironically. Diet, as was spoken about by Dr. Hirsch. Discontinuation of your PPI. And just say no to antibiotics, okay? People go to their physicians with a bit of a runny nose and a cough. They demand almost a course of antibiotics. That's one of the most important things you can do to avoid this window of vulnerability, okay? Decreasing the risk. It says here probiotics, but really none of the current probiotics adequately replace the normal fecal flora. I think Dr. Hirsch showed that this is a complex organ down below. Millions and millions, trillions of bacteria, some of which we can't grow. We know they're there because of the elegant omics studies that we can do. We can't grow the little things. So probiotics, unless they really contain a lot of the essential organisms, Bacteroidetes, different firmicutes, probiotics won't really do it alone. But diet, this is an interesting one. There's no really good evidence that diet affects the recurrent disease, apart from some work recently funded by Abbott Nutrition. And they showed experimentally that butyrate, which is a short-chain fatty acids, actually affects the fitness of C. diff. So butyrate basically reduces C. diff activity, and it may lead to diet-based strategies in the future. So it can augment some of the efforts we make to replace the bacteria, but also help supplementally with compound like butyrate or organisms that make butyrate. And I'm banging the drum again, antibiotics, okay? Avoid clindamycin, cephalosporins, and fluoroquinolones. So antibiotic stewardship, that is what it's called. So the issues during your window, what are you concerned about? Bowel habits. You will obviously keep a very close eye on that. You need to maintain home environment is clean, it's thoroughly disinfected. You need to get rid of the spores. And then you're concerned about giving this to your children, your grandparents, and so forth. So those are the sorts of things that are front of mind. So you do have diarrhea. What do you do next? Well, you go to your primary care or the person that looks after you, you discuss the signs and symptoms. Some patients that don't have the ability to do those discussions, make sure your caregiver understands this as well. You need to establish what I call the veracity of the test that will be used to establish whether you do have the disease or not. Asymptomatic colonization is a problem, only because it can lead to physicians giving you antibiotics that you don't really need. So how do you prove that? So to ensure that you have a true infection, you're not just colonized, and then you get, courses of Vanco or metronidazole, which you don't need. And remember, they are antibiotics. In of themselves, they do affect parts of the microbiome. So any antibiotic that kills any bugs, be aware, okay? So in order to avoid unnecessary treatment of the colonized patients, your care provider really needs to know what sort of tests that your stool sample is going to undergo. There are some tests that say, sure, there's the genetic wherewithal to produce toxin. It's in the memory of your bowel, but they're not producing infection. It's a sort of memory, okay? You want to know that the organism is actually there and the organism is making the toxins that make you ill. And there are a variety of challenges with trying to work out which is the best test. And although, there is debate about this, IDSA guidelines are really quite specific. First of all, do not perform tests on patients within 7 days of your treatment, okay? Or even during the same episode of diarrhea. Do not test asymptomatic patients unless you're doing an epidemiological study. Okay, that's fine. Patients with unexplained new onset, 3 or more unformed stools in 24 hours are the patients that need to be tested. Which tests? There's a whole slew of different tests. They basically fall into 3 categories. A test of what's called glutamate dehydrogenase, which is characterized with C. diff. A toxin, there are 2 toxins, I think we explained that earlier, toxin A and toxin B. You want to make sure your toxin is there as opposed to the genetic memory. And nucleic acid amplification, which are all the buzz because they're relatively quick, they detect the toxin genes. I don't expect you to read that, but there's pros and cons of each one. IDSA guidelines basically say the bottom line. Multi-step algorithmic testing is advocated by international guidelines to optimize the diagnostic accuracy. So when you've had your course of antibiotics, and beyond that, if you have a bout of diarrhea, make sure that what is being sent to the lab is tested appropriately and you don't get led down the pathway of colonization, you have disease and you receive therapy. Make sure you really do have disease and that your window of vulnerability is real or not. So what are the sorts of questions and the tips to control when you get diarrhea? And here I've really gone for the traffic light system. This has been developed with the National Transition Care, the continuity group, and they ask standard questions on discharge. What the patient needs to know about the illness. How can they prevent the disease from spreading? What precautions can they take when they go home? Now, many of you are patients. So you'll know the answers to some of these questions. But a lot of what I'm going to call CDI novices don't know the answers to these, and they are the ones that can fall in the window of vulnerability. And they are the ones that need to know the answers to this. So, what symptoms do I need to watch for? Is it just one runny stool? Or is it a number of stools per day with abdominal pain and some of the other characteristics that Dr. Forrest mentioned? What's the best way to wash your hands? I think in COVID we all got told sing happy birthday. That still works, and it's still the best way, okay? People get bored with singing happy birthday, but that makes sure that you're washing your hands with soap for long enough. You would be amazed how many, excuse me, Paul, but you would be amazed how many physicians are really not very good at singing happy birthday. I've been there, seen that. Anyway, that's important. That will make sure you don't transfer it to your kids or to your grandparents or whoever. What's the best way to clean my home? Give people the direction. Disinfectants are ideal. Do not, I repeat, do not use alcohol-based cleaners. All they do is just enrich the spores and you make things worse. Who do I contact if I'm worried about my illness? And you saw before some of the concerns, and Dr. Forrest went through some of the humanistic situations that you come across: anxiety, depression, inability to work, reluctance to go to social things. Some people I hear about haven't been outside of their house for months and months. Now, there should be a way to avoid or reduce your chances of having a recurrence and get out of that window of vulnerability. So you can do some constructive things that will help. And my traffic lights here, you probably can't read it at the back, but just to run through: green, all clear, no problems. Just keep drinking lots of fluids, eat normally, lots of fibre. You're feeling better. No fever, and your stools are formed. That's good, okay? If you have any problems, go and see your primary care. Yellow zone, this is caution. You're feeling unwell, nausea, maybe some vomiting, loss of appetite. I'm sure you've all been there. Not drinking, not eating properly, stomach cramping and pain, frequent loose stools. And I'm sure, I'm not going to show it here, but I'm sure that you're all familiar with the Bristol stool scale. And if you are, 6 and 7, anything less than 6 and 7, you ain't likely got C. diff at that time. Call your provider to discuss how you're doing. You may need to adjust your meds. Maybe that you're on a PPI. Okay? And whatever you do, if you go to the physician with a bit of a runny nose, bit of a cough, do not expect an antibiotic. And if they offer one, say, thank you, but no. And then the red box, severe abdominal pain, you really are unable to drink, you're vomiting, shortness of breath, chest pain. How many people think about that? And clearly, lots and lots of profuse, frequent diarrhea. And the one thing that really, I'm not a clinician, I'm a bench scientist type person, but I never appreciated the feeling of confusion and the inability to think properly. I'm familiar with that. I've done a lot of work in the field of pneumonia, and confusion is a problem there, and it lasts a long time. Obviously, if you fall in the red zone, you should be going to the emergency room. Okay? Finally, I think there is a saying, but I'm not quite sure how it goes, but it takes many people to make a village. And your village is avoiding the window of vulnerability. That's what you've got to do. And in order to do that, you have to have lots of players that actually talk to each other and communicate to you. And this takes a lot of coordination. Generally, folks like case managers are very, very helpful. They have all of the strings. They know who you've been treated by, what you've been treated by, what you're being prescribed for when you leave the hospital. They'll talk to the pharmacy, both in the hospital and out of the hospital. There's a whole range of things that come together. And it's that knowledge that patients must have in order to improve their self-care and avoid that window. Recognise the symptoms of C. diff. I think this room probably will. And you must be aware of continuing appropriate treatment even after you've sent out and going home. So the effective transition is the transition of care process and reduce the risk of recurrence, hospital readmission, as you heard from Dr. Foyster. That is, as we say in England, that is not infrequent. We love double negatives. Department visits and complications, sepsis, surgery, and so forth. So it's a nice circle, but it shows that all of those spokes go to the centre, go to the hub of you, the patient. And it's that coordinated patient care, it's that attention to detail that makes sure that when you send a stool, it's managed properly, that you really do have disease. So, to remove the CD sharks that will affect your window of vulnerability, please avoid the predisposing risks. Restore and maintain your gut environment. And by that, things like FMT, live biotherapeutic products, all of that. And really, only seek help if you're having signs and symptoms. And the doctor and yourself can discuss what to do next. That's me. Thank you very much indeed. Thank you. I'm not sure if we're allowed to, but I'm happy to take questions. Please, yep.
Which category would amoxicillin fall under, and different categories of risk?
Amoxicillin really is in, I think, the high risk. I would avoid amoxicillin, clavulanate. They are not good.
Okay. And the reason I asked that, I'm a survivor, and so is my little girl who's 18 months old at the time. And right now I work in a school part-time as an aide. And I have noticed that about 90 to 95% of the kids in my classroom have been on amoxicillin multiple times because of recurrent strep infections.
Yeah.
And I'm very concerned about that, when maybe something less broad spectrum could target that. But just have so many children on such high antibiotics, it's really scary.
Yes, it is. Now, one of the things about little kids is that they tend not to have as much, or they have C. diff, but they tend not to be as, how can I put it, susceptible to the infection. We're still trying to work out why. But a number of children are colonized. Whether it manifests a disease, not so often. If it was my child, in this case my granddaughter, I would prefer her to go on to tetracycline, even if it's only briefly. I know tetracycline can be an issue with teeth and bone disease, but for literally 5 days, that will get rid of the strep. If you're worried about it, yeah. And I can see with an open mouth. The other one you could try is, help me here, Paul, we call it Bactrim, trimethoprim sulfonylurea. Yeah, that's another one that is still Bactrim. That's another one. That can work. Yeah. That works against group A strep. And that's the... Yeah. Bactrim, I'll keep using it, that. Septrin's the other word. They are still quite effective against group A strep. Penicillin carries the risk of penicillins will drive the risk of C. diff. And quite often, kids are sent home from school because of strep. You need to be strep tested because there's an awful lot of other conditions that can mimic strep. And it's a relatively easy thing to test for. And if you can reduce the number of antibiotics that your child is exposed to, the better. Okay? Sorry, yep.
So given the current recommendation for algorithm testing, what's the practical implication
I would advocate, if you're positive PCR and you're negative toxin, then I would think you've probably not got C. diff. And there have been an awful, if you watched what happened when PCR was introduced, CDI rates went up. But now the PCR tests are being less favourable because of the guidelines. It's starting to come down, and I think you saw some of the numbers before. I'm a believer in the two-step method. I know PCR is quick, but you do get false positives. Yeah? You look sort of unsure.
Well, I mean, you need to do the ELISA test eventually anyway. What's the added population level? What's the added benefit of the increased sensitivity of PCR?
I think, personally, I don't think there is a benefit just using PCR straight off the bat, because you need to what they call reflex test. So go straight in, detecting GDH, which means you've got C. diff there, and then EIA for the toxin. Not the gene of the toxin, but the actual toxin, and you've got the organism. To me, that's the way to go. I feel that a number of people go to PCR because it's quick and easy. And I think we're getting some false positives. Any other questions? So we'll all think about sharks. Thank you.